Hi, I'm Mr Shyamalan, consultant hand surgeon. I'd like to do a patient educational video on trigger finger. I'd just like to talk a little bit about what to expect from a consult. At the consult, usually, I'd just like to go through the history, which is what kind of symptoms you're having, and also an examination of your hand. For trigger finger, symptoms sometimes are generally quite straightforward. A patient notices that their finger locks down in one position, and then as they bring up the finger, it clicks out of position, and that's where the triggering comes from. It can happen in any of the fingers, and occasionally it can happen in the thumb. Sometimes when the triggering is quite bad, the finger stays down in one position, or in the thumb, for example, it just doesn't bend. And occasionally, they haven't got any triggering at all. It's just very painful in specific areas. Because as the tendon runs into the tunnel in the fingers, there's a tight sheath. And either the sheath gets a bit thickened or the tendon gets a bit thickened, but either way, it just doesn't glide very nicely. And that's what causes the pain and the problems related to it. Investigations-wise, we tend not to get too many if the patient's showing an obvious triggering. Occasionally I may get an X-ray or an ultrasound scan just to look to see if there's any inflammation around the tendon, because rarely it can be due to some inflammatory conditions such as rheumatoid arthritis. Certain groups of patients more commonly have triggering, like diabetics, but on the whole it's quite common generally, and you can get it in any finger, in any hand. And those people who have had it once tend to know when they start to get it in another finger. Treatment options wise generally comes down to early presentation of just anti-inflammatories, massage and rest, and avoiding certain activities that may cause it. But we do use steroid injections, and the purpose behind a steroid injection is to unlock the tightness. And actually they're quite effective, up to 50–60% in the digits of improving the trigger finger. If the steroid injection works for a few years, you can certainly repeat a similar option, but occasionally it just doesn't work or it comes back, in which case we consider surgery. Surgery for trigger finger is a local anaesthetic procedure. It takes about 15 minutes, and it's day surgery, so you're awake. We tend to keep the patient just in for an hour or two after the surgery, make a little incision just at the front of the finger, release the sheath over the tendon, not the tendon itself, and then you can actually see the patient moving in front of you and it doesn't click anymore. Simple stitches, and they stay on for 2 weeks. And generally the wound heals by 2 weeks. The rehabilitation aspect of things is quite quickly. They can use the hand for using a pen, cutlery, but I would advise keeping the wound clean and dry. Once the wound's nicely healed, you can return back to most activities, including driving, really looking at to be near normal by 6 weeks. So generally it's a good procedure with a good recovery. There is a small percentage of complications with any surgery, whether it's related to the wound itself healing or the sensitivity around the wound, very rarely infection. Recurrence, which means the triggering come back, is quite rare, but it does happen, either because the condition wasn't the actual diagnosis, perhaps there was another problem that may have caused it, or very occasionally from scarring again, that can cause the triggering. Rarer complications such as pain, stiffness and lack of movement in the hand, actually making the hand a little bit worse, it's very rare. But the key thing for any complication is that actually the rehabilitation has to be a little bit worse than where you would expect. And certainly I would follow patients up to about 2 to 6 weeks just to make sure they retain most of their function. Because with any complication, if you pick it up early, actually you can treat it. Generally it's a good procedure with a reasonably good outcome, not always requiring surgical treatment, and I would say the majority, probably 60–70%, can be treated with minimally invasive treatment.